What you come in with certain findings. They'll say you have congestive heart failure. Why did they document the congestive heart failure? Because that's a high dollar code, right? Then did you actually have congestive heart failure? No, you didn't, right? Now I'm not saying, here again, it's a very important distinction.
Yeah.
They're not outright lying.
Yeah.
You had the coding criteria for congestive heart failure. Now, did they actually think in medical terms that you had congestive heart failure?
Yeah.
They didn't, right? But did they code it? They sure did. Why? Because they treated you for it, because you met the coding criteria for it, right? Now, where you see this play out is down the line, 5 years later you come in, somebody sees you, they look at your diagnosis list and they say, oh yeah, you have congestive heart failure.
Yeah.
You don't.
Welcome back to Dear Healthcare, It's You. Welcome back to Dear Healthcare, It's You, where we're talking about the broken American healthcare system. We've got Dr. Elisha Yagmai with us, and I am Jo Hanlon. Last time we were talking about you being in Seattle, and we didn't fully cover that story, but we were talking about how there was just an overuse of admitting to the hospital from the ER, and then this debate that you were kind of faced with about how far you should treat someone before it becomes unkind, basically, in that situation. But I know there's more to that story in terms of especially your last year in Seattle. So maybe we can pick up the story there. What was so different about, or what happened in your last year that was so formational for you?
It was really more a crystallization of a lot of things that had gone on before. So when I go back and look, I started making notes after I finished residency and just went out, notes about patient encounters, random things that I experienced, just so I would have some memory of them as I went on. And it's really interesting, actually. I went back and reviewed those notes recently, and I saw that in the first few years, actually, out of residency, I was very excited. I was I wanted to explore new subjects. I wanted to research things. I wanted to, ask new questions. And I saw that by the third year out start to erode. And instead, what I was recording was negative experiences. I didn't have nearly as many positive thoughts in terms of here's a thing I want to create, here's a thing I want to do. Instead, it was, this is really sort of wearing me down, and here's negative case after negative case. And I don't mean necessarily bad outcomes.
Yeah. I
mean it's been described before. Other physicians have used the term moral injury, but something like that, I think, going on.
Moral injury to
Moral
you?
Injury to me, yeah, to me. And many physicians have articulated this, and it comes from, it's just a variety of different sources. But, here again, I think the key emphasis is that everything I saw there, I have since seen lots of other places. So it's not that place was uniquely bad or uniquely burnout prone. They were just doing what everybody does. So what I thought at the time was unusual, as I went out into the world and worked in more places and saw more places, what I realized was this is pretty normal. This is how it is.
Were you experiencing new things there in terms of you were at first thinking it was just there, and you were talking about having looked back at these notes and seeing that transition in yourself? Was that just having dealt with the same things again and again over time and then it wearing on you, or was it new things that you were seeing in those later years in Seattle that were making you more jaded or overworked or things like that?
Yeah, what I saw was, so Seattle was ahead of Kansas in terms of billing maximization.
Okay.
Kansas was further behind at the time. And bear in mind, in Kansas, I was in a training environment, right? I wasn't responsible for the billing. I was responsible for trying to learn medicine and trying to care for the patient, right? Okay. But I wasn't the one who was ultimately in charge of how does all this get billed and paid for, right?
Which is, once you're out of residency, that's then
right.
on your plate.
Exactly.
Oh,
right.
okay.
So this was the difference. And Seattle was just, the hospital system there was just better at it. They were better at everything. They were better at hitting their quality metrics, so-called. They were better at making the documentation look better. They were better at finding ways to make the coding look as high as possible to collect the highest payments from insurance. These were all things that they did. And then on top of that, the volume of people was higher.
Right.
So the number of cases coming in was higher. The level of complexity also was in many cases at least equivalent, if not higher. Right. So all of these things were happening simultaneously. and I think my assumption, I should say, is that a lot of physicians sort of go through this transition.
Yeah.
But there's multiple things going on. So when we talk about, I think our intent in this episode was to kind of talk about how did I get burned out on this system.
Right.
And hospital systems have spent money on this. There's been research on this, right? Probably the most effective phrasing that I have heard about it actually came when I was driving around rural Kansas one night, and I heard a guy talking on the radio who said, burnout is not working too hard. It's when you're working too hard on the wrong things. And
which in Seattle, when you started there, if I recall correctly, you were excited by how much there was in terms of just access to people who knew more than you. I mean, it was such a robust system in terms of the care available. And so in these latter years, you started to have this burnout from those same like the other side of that same coin sort of thing.
Yeah, I think initially it started with the other side of high expertise, right, is kind of what we had alluded to in the previous episode, right? No one knows how to shut it off.
Right.
So the initial problems were patient comes in with clearly terminal illness, right? And we are forced to continue providing care even though it's obvious that it's going to be terminal.
Right.
And what we're doing is, in terms of personal ethics, is not obviously the right thing to do, but it is the expedient thing to do. It gets everybody paid.
Yeah.
And it avoids any uncomfortable conversations that we may have to have about the fact that your life is coming to an end, right? Or your loved one's life is at its end, and it's time to acknowledge and accept that fact. Easier instead to say, oh, look, we can do this, we can do that, and oh, by the way, it pays us $20,000 when we do that, right?
Right.
All that gets a little muddy, right?
Yeah.
So we had, episodes that fit into that, particularly well. And I think I described one, in the previous episode. I still remember there was, here again, talking about how the healthcare system works, there was a patient that we had that was probably 30 years old who had had pneumococcal meningitis. That's a bacterial infection of the brain as a child. It had left her blind and, if I recall, deaf. And as a result of various illnesses that she'd had after that very severe illness, over time she'd had her arms and legs amputated. So she had stumps for legs and stumps for arms, and she was blind and deaf. So she was a blind and deaf torso in a bed, right? And she would periodically decompensate, and her father was providing her care. The family had long since, I think, broken up. They're divorced, and this happens to a lot of families that care for chronically ill children and others. And so he would periodically bring her into the hospital for whatever the thing was and disappear. He would just disappear. And in fact, what we learned later was that this is how he would take a vacation.
Really?
Yeah, because there was no way to care for her. He couldn't, here again, it's the American healthcare system, right? So it's not like he could afford in-home care, right? So the solution to this was to come up with a reason that she needs to go to the ER, get her hospitalized, disappear for a week or two or whatever it was, turn off his phone, completely unreachable.
Wow.
So you'd bring her in and you'd fix the problem in 12 hours, or if there even was a problem, right? Whatever it was, right? And then the patient would sit there, right? And you would be sitting there looking at a person that is in every way non-functional, is not able to interact with the world, is not able to do anything. And on top of that, I say blind and deaf, it wasn't like someone was home cognitively, right? Like cognitively, she was destroyed by that infection. And so you look at that and say, okay, so at age 3, I think it was age 2 or 3 when this happened, right? This is when this person's life effectively ended.
Yeah.
Here we are at 30, still going.
Right.
Why are we still going?
Yeah. What is the alternative, though, is just to deny care and let her deteriorate at home?
Well, the alternative would be to have I think on some level, it's as a culture, our culture is terrified of death.
Right.
We're absolutely terrified of it.
Yeah.
We do anything to prevent it because it represents the unknown, right? And
Yeah.
people assume that if it's unknown, therefore it's bad, right? Obviously, nobody really knows, right? But people have theories, and obviously there's whole religious structures and philosophies
we really
built
like control
around this.
and yeah.
So this is
control
an
of it.
area you don't have any, right?
Yeah.
So for many people, death is viewed as the ultimate evil, and therefore anything should be done to prevent that from ever happening. But when you work long enough in clinical medicine, you realize in some ways there are things that may actually be may be worse than death. They may be worse than death. Now, I'll say there's...
Speaking to like the quality of life side of things.
You have no quality of life whatsoever. That said, I mean, I think I should also acknowledge there have been research papers that have been published on this that said medical professionals have a much more dismal view of this than the general public. Like people in the general public that were interviewed said, yeah, even if I had a terrible deficit, I would still want to be alive. It's still better than being dead, right? Whereas the medical professionals were like, if I have a deficit, like put me down, right? It's just a totally different, like there's something about that culture. You know, now some of that may be informed.
They've seen it though too many times.
That's the opposite, right? The healthcare professionals see it. Like we see what that really entails, right? Whereas the general public, you know, they're imagining a thing that in many cases they may not have seen. But there is still some disconnection between how healthcare professionals feel about death and dying and disability and how the general public may feel, right? Depending on what their individual experience has been.
Right.
But the point was that in that environment, so one, I'm seeing this, right? I'm seeing things like, and then let's get, you know, even more pernicious. There was a guy that was addicted to heroin. He came in, he had a stroke. The reason he had a stroke was because he had an infection on his heart valve. But the problem with his stroke was that it left him like he was gone, like he was what we call obtunded, right? He was just basically unresponsive.
Okay.
So when we figured out that he was not waking up, right, and he had an infection on his heart valve, which in turn he had gotten due to his heroin addiction, right? You inject drugs, bacteria get in there, they can land in your heart valve, right, and they can set up an infection there, right? So when we learned this, right, the obvious assumption was, well, you know, we're probably done, right? We have an infected valve, and there's nobody home cognitively. And he had obviously a very severe addiction at baseline.
Right.
They did a valve replacement on him. Right. They did a surgery to replace his valve. Wow. And I was left saying,
did he have any family there, like to consent or anything like that?
If I recall correctly, I don't think he did. Is
that a factor in that when it's like you don't have somebody to ask to?
Well, it works both ways, actually, right? So when there's no family around, then it usually comes down to the opinion of the treating physicians. Okay. That's what wins the day, right? If the family is not there to register an opinion, right? If the family is there to register an opinion and the patient can't speak for themselves, then it's a discussion, right, between the physicians. But in this situation, if I recall correctly, there wasn't necessarily a great push, right? It was just this, again, we can't turn this off, right? And so the question you had to ask was, what's the long-term play?
Yeah, like was there hope for this patient that he would come back on?
Well, I think
like come back consciousness.
I think that was the way it was sold. Right? Yeah, maybe his brain will come back at some point, right?
But realistically, that was not a high probability.
It was not a high probability, right? It was not a high probability, but this was done anyway, right? It was very much, again, we discussed last time, kind of forest and trees, right? Okay, I know how to fix heart valves that are bad, right? Yeah. Okay, I can take this one out and I can fix it, right? This is what was done, and yet, again, right? It's at least worth a question. Yeah. Was that the right decision?
Is the patient's insurance known and brought into the equation when these decisions are being made?
Absolutely. Yep. If they have insurance that will pay for a thing, that thing is more likely to happen. That's absolutely more likely to happen.
Is that part of what, like you mentioned the billing side of things before, or, you know, having more of that on your plate and in your view? Yep. Is that the main thing that made a big difference for you in terms of seeing these situations play out? Or was it already that you were seeing these situations in your first couple of years there and like that they were sitting wrongly with you? Was it more about understanding that connection about the payment being such a factor?
Yeah, I think, well, no. So I understood it. I already had a concept of that, right? But at that time, I thought, this insurance stuff is basically a game, right? We have to play this game, right? Because this is how America has decided to set up its system, right? Mm-hmm. So if we want to care for our patients and we want to be able to keep providing care for future patients, we have to generate revenue. How do we generate revenue? By billing insurance companies, right? And to bill insurance companies, there's a whole game of compensation. Mm-hmm. There's rules about how you do everything, right? And you try to optimize your function and documentation relative to those rules to seek the maximum reimbursement. And the way that's justified is, well, we have to do this, right? We have to do this to continue to pay people to be able to do the work, right? Right. That's what it is. Where it goes wrong is when that becomes a priority in treatment.
Like over the deciding factor of what's best for this
That's the reason
patient.
of why this is done or why this is not done, right?
Would you say that you've seen that happen elsewhere? Like, is that part of what you were saying? Like, that you've seen all over? Is that
years later in rural Kansas, there was a patient that was brought in. He was severely developmentally delayed, cognitively extremely challenged. Like basically, and I can't now remember what all had happened, but what his life was sitting in a chair and drooling. This is what he would do. I mean, that's not an exaggeration. That's what he would do.
Yeah.
There was no way to interact. There was really no obvious meaningful interaction really in any way. So he, at some point, passed out. I think he passed out, got brought in to the emergency room. Long story short, he got transferred to a specialty hospital where they put a $35,000 defibrillator device in his chest.
In his chest?
Mm-hmm. Yeah, they had to do a procedure to stick it in there, right? So they did. They stuck it in. At that time, I think it was billing out at about $35,000, if my memory serves correctly. And again, right? You looked at that and said, why did we do that?
So in terms of someone like this, where insurance would pay for them for their treatment, it's not going to land on them in terms of debt or their family or whatever, but they don't have a high quality of life now, you would feel like that's unethical to do in your shoes with what your experience has been and the things that you've seen. You feel like that would be unethical to keep doing that, even if it's not detrimental to the patient?
Well, I would say for one, it's detrimental in the sense that you are exposing them to the risk of a procedure, right? No medical procedure is risk-free.
Yes.
Almost none. There's just, so there is some risk associated. So there's that. There's the cost, right? So we as you indicated, okay, so maybe they've got various types of public insurance. Maybe they've got Medicare and Medicaid, just for example, right? So in the end, they're not going to get a bill out of it because of the special needs that they have. Fine. But who is paying for that? We are. Society is paying for that, right? Because they don't get their money from nowhere, right? It comes from taxes. Yeah. And here again, you can say, well, in this one-off situation, maybe there was, right? But this one-off situation is not a one-off situation, right? This is happening hundreds or thousands of times across the country on a regular basis, right?
Is it happening more so with people who have like marketplace fund? Now it's marketplace, but government-funded healthcare?
That I could not answer, only in as much as people that have severe cognitive problems often end up on public insurance because they cannot be employed, right? So I would say that probably does occur in that context more, but not necessarily because of that, like not because they're on public insurance, if that makes sense, but they just happen to be on public insurance, right? And all of this, here again, why is this possible, right? It's possible because the whole system really runs on documentation, not reality, what you write. If you write the right thing, then you're justified to do whatever you did, as long as you write the proper thing in the box, right?
Interesting.
So the analysis of the actual case may never actually even go on. As long as you write the proper words, then this will be paid for, right? That's a very tempting situation for a lot of people. We see a lot of fraud in medicine as a result of this, right? Because all you have to do is write the right words and check, it's good.
And that ultimately just will go, does it go to your superiors or it just goes to insurance?
It goes to insurance, yeah. I mean, here, and this kind of takes me to, so that's sort of second point in this, right? Which was, the focus again was on things like documentation.
Right.
Not necessarily on how good of a job are we doing, or are we doing the right thing. It was on documentation. So there's another story, that comes to mind with this, where you got to remember at this point I'm 2-3 years out of residency, right? So what I want to know, what I very badly want to know is, am I any good at this?
Right.
Am I any good at this?
Did you feel like you were getting better?
Yeah, I thought
you were exposed to a ton there.
I thought I was good at it, right? I hope I was. Yeah. But in objective terms, am I any good at this or not, right?
Right.
How does my work compare with that of my colleagues in any way, right?
Is there any way to tell?
Very little. Very little. Yeah. It's not a focus. It's not an emphasis, right?
Yeah.
And usually the answer given, if anyone even thinks about it, which they rarely do, is, that's hard to determine, right? And I'm like, it's hard to determine, but there are some things that we could measure that are objective, right? That would at least give us the beginning of some clues, right?
That are not measured, though.
That are not measured. Yeah, in general, they're not measured, right? Or if they are measured, they're not shared with anybody.
Right.
Right. So and I was learning this right as I went along. I was like, okay, so we see variations in practice. I'm like, well, okay, so let's you do it this way, I do it that way. Like, which way is better?
Right.
Are they the same? Is one way better? Do we know? Does anybody care? No, the answer is no, right?
Yeah.
But what was cared about was what you wrote in that note. Right?
For insurance billing.
For insurance purposes. So in one case, I had a patient that had been hospitalized for 60 days, and all kinds of things happened. I came on to service on the 60th day of her hospitalization. This is when I picked this patient up, right? And I had to write the discharge summary. So as a discharge summary, I mean, most people that are in hospitals know, it's an incredibly annoying thing you have to do. This is summary, and especially when you're coming out at the very end of the case, where you got to go back through all this stuff and figure out what all happened, make sure everything is accurately reported. So I go through, I do this discharge summary, and I fire it off and move on to the next patient. So week and a half, 2 weeks later, whatever it is, I get a response saying, hey, in your discharge summary, you forgot to document hyponatremia, which is low sodium. You forgot to document this. And I was like, well, that's interesting because I don't even remember there being any hyponatremia in this case. It certainly wasn't significant. It was there.
Yeah.
So I went back and looked, right? And on day 29 of 60, there was a low sodium documented. The low sodium was 134. The bottom limit of normal was 135. The next day, it was lab. It was just lab variation,
I was gonna say,
right?
that's just air.
The next day, the sodium was back to normal, right?
Wow.
So this was, number one, probably not real. It was probably just lab variation. Number two, irrelevant clinically.
And wasn't treated.
Wasn't treated. Nothing was done. Nobody even commented on it because it was irrelevant. Right. However, for billing purposes, at that time, hyponatremia was a so-called high-value code.
Oh, okay.
Putting it in the chart raises the payment that the hospital receives.
Even though there's nothing that was treated about it.
Correct. The final diagnosis, the diagnoses that are shipped off to insurance, right? They're put together in a package called the diagnosis-related group, right? And the more of these high-level diagnoses you can slam into the package, right, the more money you get coming back to pay you for the hospitalization.
So you're getting payment for not just treatments, but for actual diagnoses.
You're getting payment for what diagnoses you document, right?
Oh, interesting.
So Americans at this point are, for example, very familiar with sepsis. People have started to hear about sepsis and such an epidemic of sepsis, right? There's so much fake coding sepsis in charts because it reimburses well, right? So everyone's always looking for sepsis. Now, to some degree, it's clinical. They're looking for actual clinical evidence of sepsis so they can catch it early, right? But to a larger degree, a lot of the sepsis, everyone knows that's not real, but you can bet they're going to document it. And the reason they document it is because it pushes that total payment up.
Wow.
Right? Now the question is, imagine this. You're a researcher. You want to know something. You want to know something about sepsis. How much sepsis is there, right? What's the prevalence of this disease? What happens in the outcome? You are generally speaking using data that is based on that coding, and that coding is motivated by financial compensation, not reality. Right. So sepsis,
all those results are going to be skewed.
It's the problem, right?
And there's no those researchers wouldn't be able to go and
very hard, right? They'd have to actually go back to the chart itself, right? And be like, was there actually sepsis here?
Yeah.
Right? Or was there not? Was this coding, what we call coding sepsis, right? Coding sepsis is, and there's certain criteria you use. Do you meet certain criteria? And if you do, and you have these combination of factors, right? You call it sepsis and you treat it that way. Right, and then because you did that, right, then you get to tell the insurance it was sepsis, and there's certain charges associated with it. There's all this mumbo jumbo that goes on. But again, the question was, what are we doing here? Right? Are we doing medicine and science, or are we doing, kind of documentation games, right, to maximize our billing?
Yeah.
Well, the answer was documentation games to maximize the billing, right? But again, it's not just, it's just a thing we do, right, to play the game.
Yeah.
Right? You're like, no, this has real life downstream effects in terms of our actual knowledge.
Yeah.
Because you are miscategorizing a diagnosis
a lot of things,
for the sake of being paid, right?
Which also would go into, I'm just personally learning about how private insurance is still, I didn't realize that the ACA doesn't go over to them, but in terms of your pre-existing conditions. So then if you had a pre-existing condition that wasn't even accurate just because of a prior billing, then it like affects you down the line
This
too
happens.
as a patient.
No, this
like,
absolutely happens. No, what you're describing happens for real,
Yeah.
right? They will say, you'll come in, you come in with certain findings. They'll say you have congestive heart failure. Why did they document the congestive heart failure? Because that's a high dollar code, right? Now, did you actually have congestive heart failure? No, you didn't, right? Now, I'm not saying, here again, it's a very important distinction.
Yeah.
They're not outright lying.
Yeah.
You had the coding criteria for congestive heart failure. Now, did they actually think in medical terms that you had congestive heart failure?
Yeah.
They didn't, right? But did they code it? They sure did. Why? Because they treated you for it, because you met the coding criteria for it, right? Now, where you see this play out is down the line, 5 years later, you come in, somebody sees you, they look in your diagnosis list and they say, oh yeah, you have congestive heart failure. Well,
Yeah.
you don't.
And you never did.
But you never did, right? But it got stuck in your diagnoses because that's a high reimbursing code. And so then that new person, right, is looking at this and saying that how they view you is changed, right? Because if they think you have that diagnosis, how they think about your problem is different than if they do not think you have that diagnosis, right? This is a real thing, right?
So if you're doing good medicine and you're actually trying to
Yes.
look at all the factors from the past and all those pieces,
Yes.
yeah, then you're getting skewed data.
Exactly. Yes.
Misinforms your current possible for diagnosis that's accurate.
That's correct. Yeah. Because I think you have diagnosis A, B, and C, but you don't have any of those things. That was never right.
Wow.
That was never right, right? It was just coded that way to maximize payment.
So in terms of how you learned this,
Yeah.
is this something that like was just from being like called out on not having included certain things from the billing department once you had written these like discharge things, and so you learned like what's high coded or not? Or
Well, the first place I learned it actually was we had an attending physician. This is back when I was an intern, right?
Okay.
This is back in Kansas, right? He said, "Yeah, so y'all gotta learn how to code properly, and the reason you have to learn how to code properly is to accurately reflect the acuity of what you're seeing, right?" Okay, because they have things called case mix indexes and other things that are basically it's supposed to tell you how sick are these patients that are being treated in this place, right? Okay. So he gave us as an example, he said there are 2 hospitals in town. One of them gets really low ratings because, well, I should say historically they had gotten lower ratings in these hospital rating systems because they appeared to be taking care of patients of lower acuity. They were not. They were taking care of the same kind of patients as everybody else. They appeared to be. So what happened was this place realized this. They brought in some coding experts to teach everybody how to write about it properly, right? And then all of a sudden this hospital went from worst to first in a very short period of time because everybody learned how to properly describe what they were doing, right? There's a huge problem with that. And so we all learned this, right? We learned this lesson. Okay, you gotta reflect your acuity properly, which means you gotta code all those things that they meet criteria for, right?
Right.
That is true. But fundamentally, as a physician, physicians aren't really scientists in most cases, but sort of a technician, pseudoscientist, you ask,
Like a body mechanic.
do we not want to know for real what this person actually has? Do we not really want to know what they have, right? Do we not want accurate information on which to base research, right? And all the other things that kind of flow from that. And the answer, I think, is pretty clearly, yes, we would want that to be accurate, right? But nobody cares about that. They care about, did you meet the coding criteria so that we can tag another diagnosis onto this chart, right? And this ultimately downstream skews everything. It induces errors, right? It produces overcoding, right? All these other types of things that go on.
Is there personal incentive to, like, are you receiving more personally as a physician when you code for these hires?
Usually you don't. No,
so
not directly.
There's not personal motivation for it. It's not like you're going to be coding off the wazoo just because you're going to make more in your pocket.
No, but your motivation.
But it's from your pressure from up above.
Correct. Yeah, your organization, right? Especially working in a hospital.
Yeah.
Your organization is getting paid for this, right? So it affects you indirectly.
Sure.
By how much money they have. And to some degree, it also affects you in the sense of, you work at the place with the highest acuity, right? So that, it's like a little gold star, right?
Okay.
Physicians are all about getting little gold stars, right? So you get a little gold star because you work at the high-end place, right? The highest end place.
Gotcha.
And you get that because you're coding properly, so you're really reflecting, right, what your acuity of illness is. That's how the game is played, right? So take that now to sort of step 3, right? So step 3 is what you alluded to a little bit earlier, right? I have a fake heart failure diagnosis, which was assigned because I met the criteria, like last hospitalization or 4 hospitalizations ago. So I now have this fake diagnosis living in my chart, right? Which is skewing what I think. Well, the obvious answer to that from the physician's perspective is, well, okay, I see a heart failure diagnosis. I need to go confirm that, right? Which means I have to go into the electronic record. I have to go look and see. They do ultrasounds of the heart. I have to go look and see, did anybody ever do an ultrasound of the heart, right? What was the function? You know, there's various things that we look at, numbers that we look at, right? I have to go do that, right?
Yeah.
Well, let's say I'm lazy and I don't do that, right? I just decide to treat you in a certain way because you have a heart failure diagnosis, right?
Yeah.
So the problem is that when I assigned that, or when I look at that false diagnosis, the electronic records in general at that time, and even up till now, though they could present you with the information to tell you this was not actually true, they don't. You have to go find that.
Yeah.
You manually have to go look, right? And that's often several clicks down the line, right?
Yeah.
So you have to find that. Now,
which I've heard you say that even just in our last episode about it feels like the whole system is so inefficient that it's like I'm hearing from you that it feels like to you to be a good physician, you have to double check everything.
Everything, yes. You have to double check it. That is absolutely correct.
Because there's not continuity across from one to the other of anything, it seems like.
Your patient rolls in, they've got records in 5 places. You have access to none of them. Right. You know that something occurred. You don't know what it is. You have the patient's story, which may or may not be accurate, especially for diagnoses and things like that, right? It's not their area of expertise. That may not be correct. You have your own chart, right? Which as time has gone on, these records are voluminous in terms of there's just so much information in there, right? But you have your own chart, which can be huge, right? And so when the patient comes in, if you're going to do due diligence, you have to check everything, right? And so the problem is that, and here again, why do you have to check everything? Because the software package doesn't do it for you.
Right.
So a lot of the algorithms that you're following, software could do this faster and better than you.
Yeah.
It doesn't because there's no mandate for it to do so.
Gotcha.
So the same vendors that sell these, $1 million, $100 million, right, electronic medical records to these hospitals, didn't build a lot of that functionality into it even when they could, right? So if I wanted, for example, to know something about your alleged heart failure, right, I have to go click through until I find that particular study, open it up, read it, right? And then it gets even worse. Let's just say I just wanted to throw it into a document to document the number. I then have to click all the way back out and manually type that number into a note, even though it lives in the software. Do you see what I mean? The software has the study in it with the number in it, but it can't bring that number from point A to point B. You manually have to do this, right? And that's just the very beginning of this. Let's say I've got 15 years worth of labs in there, right?
Right.
I got to go back through those labs and I got to look and see, okay, well, how are things trending? Like, are we missing anything? Is there something that went on back there that's been kind of trending the wrong way for a while? Maybe nobody's been paying attention to.
Right.
It's a very real thing. Was there a cancer on a past CAT scan that nobody bothered to pay any attention to that wasn't flagged anywhere, right? That's real stuff. That's happened, right?
Yeah. Where you're literally looking at the images and seeing it there.
You're looking at it, right? Or even you're looking at the report and you're saying, I think I talked about that even back in residency, right? But that's a real thing, right? This happens. So there's a finding that's important that never got flagged. No one knew anything about it. It never made it into the record, right?
Yeah.
Their sepsis did, but their the tumor on their CAT scan never actually did. So to my knowledge, it doesn't exist because it's not anywhere in their diagnosis list, right? So the only way I can know it's there is to go back into that.
Well, and because the patient wouldn't even know.
No, they don't know, right? No, because here's what happened. The study was done on the last day of their discharge. Nobody quite looked at it. They got discharged home. Nobody looked at it. The primary care doctor didn't see it either. Nobody quite knew it was there. Right, so how do you find it? You have to go back and you have to look at all. And it's not like the electronic record was smart enough to say, hey, there's a tumor. Anybody respond to this? I don't see a diagnosis corresponding to this, CAT scan report. This is all stuff that software could have done, even a few years ago. Software could have done, wasn't doing. Right. So your responsibility, your task as a physician in this context, is to go back in detail on all of these things. You have to check everything that's been done up to this point. You have to double check the diagnoses and confirm if they're true. You have to go back and look through the data to see, is there anything in this that nobody has commented on, no one knows about, right?
Yeah.
And you find stuff. And the thing is, you find stuff. And you find stuff with enough frequency that you can't Stop doing that.
Was everybody looking into stuff like that?
No, not everybody was doing that. But this is exactly what happens, right? So imagine now you're carrying 15, 16 patients. They're fairly complicated. They have all kinds of problems and diagnoses and various other things going on, right? This puts and here again, this is what leads to the burnout. This puts the physician in an impossible position. Because what I was doing,
it sounds unsustainable.
I'm going in at 7 a.m., right? I'm going all day, right? I finish up at 7 p.m. or whatever it is. I go home and I chart for 4 more hours. Easy, right?
Charting what you've been working on or going through past stuff.
Both, yeah. Right? So I'm writing down what I did that day.
Yeah.
And then I'm also going back through past data, right? And I have to do this at least once in admission for every patient if I'm doing my job properly. I have to do this, right? And so I'm putting in all that time, and sometimes when I say 4 hours, it could be later than that, right?
Sure,
so sometimes I'd be finishing up at 1:30, 2 in the morning, right? And then I got to get up and go back in there at 7 o'clock, and then do it again, 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 right? All this is happening, and if I don't do this, I'm doing a disservice to my patient who trusts me to try to provide the best care I can, right? But providing the best care I can means I have to sort through all of this chaos that's produced by bad, deficient software, by misaligned incentives, right, in terms of accuracy.
Yeah.
Right? I have to sort through all of this to try to find what the actual truth is, right? And so what you end up with is a situation where you are forced to choose between killing yourself or killing your patient. Wow. This is the choice you have to make because every time you don't do diligence, there's a risk, right? Yeah. And I don't mean malpractice risk. I mean there's a risk to a real person, right? You're going to mess something up. You're going to miss something that dramatically affects their life in a negative way, right? But the amount of effort and energy you have to put into that, right, is grinding you down to dust over time. This is the issue,
so
right?
do most people just not do it then?
A lot of people don't. I can't speak for most, right? It's going to vary from physician to physician. But yes, a lot of people cut those corners. They cut the corners because they're like, you know what? My kid's got a baseball game. I got to get out of here.
Because I mean, it sounds unsustainable in a way that it must be such a hard thing to continue to. I mean, it's just burning. It's a burnout system.
Yep, it just burns you.
So, were you ever influenced or persuaded to miscode, like intentionally for a higher code?
No, I didn't. I had only one episode. So, when I would code by criteria.
Yeah.
If they met the criteria, I would code it, even if I knew very well that clinically that was not what they had.
Okay.
And that's because that's the game. That's what you're supposed to do. It's not even like it's illegal. It's just a thing that doctors do, right? They're instructed to do it. You're taught how to do it. This is the thing that you do. I had only one episode where someone asked me to falsify a code, and that was where the patient had a post-operative infection, and the surgeon came up and asked me to call it something other than a post-operative infection because that dings your payment.
For the surgeon.
For the surgeon and for the case, right? The hospital can lose payment. I forget how it all works now, but I think if you get readmitted for a post-op infection, that comes out of their hide in some way, right, financially. Yeah. But again, let's go back to the question of accuracy, right? So the purpose of having a penalty assigned to post-operative infections to try to reduce your risk, to force people to pay attention to post-operative infection, try to reduce the risk of that, right?
Right.
But wouldn't you want to know accurately when there is a post-operative infection so you can figure out who your worst offenders may be in terms of post-operative infection and investigate what they're doing? Or for that matter, I say worst, who your best people are and what are they doing, right? That makes them superior, right? But you have a strong disincentive to tell the truth because it hurts you financially to tell the truth, right? So here again, you're a patient. You're like, I need a surgery. I want a surgeon that has a low post-op infection rate.
Right.
You have to hope that the surgeon is honest. You have to hope that the hospitalist was honest. When you're looking, if you can even find their post-op infection rate, which I challenge most people to do, it's very challenging to even get that information, but if you could find it, you have to hope that everybody involved in any post-operative care was actually honest about it.
Yeah. Because
it's just a matter of saying, oh, okay, it's not a post-operative infection, I won't use that word. I'm just going to say, oh, they're septic due to an infection. They had a soft tissue infection.
So in terms of their medical record, it could be similar, but in terms of the actual surgeon's record,
correct.
Then you have skewed data now.
Exactly. You have skewed data, which makes the post-operative outcome look better than it is by hiding an infection, by naming it something else, right? Now you say, well, that's ridiculous. You shouldn't be able to get away with that. Well, the reality is, do you think anybody's actually looking through the charts regularly to see, oh, yeah, you falsified it here. That wasn't just an infection, a soft tissue infection. That was a post-operative infection, right? It occurred within whatever, 1 day of a surgery or 2 days of a surgery at the surgical site, right? Which is exactly what that case was, right? So in that situation, I did not do that. But I was like, this is an awkward situation, right? Because what I'm basically having to do is I'm having to take a step which dings one of my colleagues, right? So now there's potential for bad feeling, right?
Right.
Dings him in some way, dings the hospital in some way, right?
Well, and ultimately, it shouldn't be potential for bad feeling because ultimately, it's nowhere near your fault, except that there's this pressure from this
pressure
person because they're part of the system.
Exactly.
Yeah.
There's a pressure to change what you write. Not to change your management, to change what you write because it makes everybody else look better.
Right.
But the problem is it makes them look better than they are, right? And all of that, again, you can kind of drift it back. Culture, medical education, if you recall correctly, right? It's all about hiding weakness.
Yeah.
It's about hiding weakness, pretending you know everything, pretending you have no flaws, right? Here we are again, right?
Yeah.
So rather than saying, let's identify the flaws, let's make it non-punitive.
Yeah.
Let's make it non-punitive. You see what I mean? Let's identify the flaws. Let's figure out why they're occurring.
Yeah.
And let's improve it.
Yeah.
We're not going to throw you out with the trash, right? We're going to acknowledge that different practitioners are going to have different approaches and therefore different outcomes. But there is something that we can learn from both the ones that are better than average and the ones that are worse.
Yeah.
We can learn best and worst practices, and we can all improve from this, rather than saying, you're bad, right? You had this bad outcome. Shame on you. We're going to take your money away.
Right.
Right? Again, what do you want your system to produce for you? What it produces now is a strong incentive to be dishonest,
Right.
which I'm not saying everybody does. In fact, most people may be perfectly honest, but you have an incentive to be dishonest, right? So again, it goes back to that sort of those ethical and moral questions, right? Of what am I here doing, and why am I doing this?
Right.
So you imagine
What is
you have all
actually
that.
best for this patient?
What is best for this patient is, as you've noticed, right? Not even really a question, right?
Right.
Not even a question.
Yeah, it's what's best for the hospital, what's best for the surgeon.
That's right.
Yeah.
Yep. This is the situation, right? So we had that element of it that's there. While all that is going on, right? You're getting just relentlessly pounded with just patients, volume of patients, more and more people coming in, right? One of the things you learn from that is, on average, how unhealthy the country is.
Oh, really?
Yeah, because you see people coming in, huge burden of disease that comes into hospitals is self-inflicted in the sense that it is due to behavioral choices, lifestyle.
It's preventable stuff.
There's preventable stuff, or at least it's stuff where we could have reduced the burden of disease, right? If we had a different food system. If we had more walkable cities, if we had more emphasis on getting rest, right? Name it, right?
Yeah.
If we had a different national culture or a different social approach, we may not all have to be here dying, right? But we are.
You're privy to seeing probably the outcome of a lot of broken systems.
That's correct. You see all of that dumping into your hospital all day, every day, right? And it's relentless, and it just keeps going, and it's high stress because people are sick. And you're expected, as we discussed before, you're expected to fix them, and you're expected to do it perfectly. Doesn't matter what time of day it is, doesn't matter what else is going on in your life, you're expected to do it perfectly, right?
While also personally not being able to rest eat or do the things that you properly would, that you're seeing the results of.
All these things are happening,
Yeah.
And so that has a corrosive psychological effect.
Absolutely.
It has a very corrosive psychological. So one of the things that we see in medicine, I've certainly seen it, is the psychological corrosion of colleagues and friends, right? Where they started in medicine as a certain type of person in a certain way, and by the time they've gone through 5-10 years of this, they hate everybody.
Yeah.
Just angry, and they're just unpleasant, right?
Yeah.
So here again, right? Patients are like, why is my doctor such a jerk, right?
Right.
Well, and some of us are just jerks, right? It's just, I mean,
Could be.
there are people that they were jerks before they became a doctor, and they're still a jerk with an MD, right? But a lot of it is this process of slow grinding that's going on. It just keeps getting worse and worse, and over time you're getting ground down, you're getting older, your energy level's getting lower, your level of idealism is now in the basement, right?
Yeah.
And all this is happening, and you're being asked to do all of this, right? And still, present this like cheerful, smiley, face. And for a lot of people, it's very difficult for them to do. And so, for people that I've known for a long time, if I look at their progression over time, I've certainly seen it. I'm like, wow, the difference between you when I first met you and you now is substantial, not in a good way, right?
Yeah.
And you can turn that mirror back on yourself. I certainly can, right? And say the same thing, right? Which is this is making me worse as a person than I want to be, right? It's just your patience, your tolerance, your kindness, right? All these things are just getting ground down and ground down and ground down, and you feel it, right? But there's what else are you supposed to do? This is your job, right?
Yeah.
So you just keep showing up for the thing.
Which speaks back to that phrase that you had heard, that burnout is not about necessarily just being overworked, but it's about working too hard to do doing the wrong things.
Yes.
Or the things that you're not meant for. And I feel like that you're describing both, being overworked, but then also overworked with a high emphasis and time commitment to pieces that were not your motivation to get into medicine.
Yes.
Yeah. Well, and with that, we're about out of time here, but I next time want to touch on where that burnout that is highly understandable, how you arrived there, and thanks for describing all of that. That's really enlightening. But next time I want to talk about where that burnout led you, because I understand that that's a bit of a pivot point in your story and takes us up to Free State, which is how you and I have known each other. So we'll pick up there next time. Thanks, guys.